Hi. So I'll be discussing in this video, I will be talking about histopathological considerations in the diagnosis of glomerulonephritis, and I've divided this into two parts. So this will be part one of that discussion. Uh, it is part 4.3 in an approach to peripheral edema. So once we've gotten our bearings, let's see what I'm trying to do in this particular with this particular video. So this is the schematic that we had used to understand the pathomechanisms of various of various glomerulonephritis and even nephrotic syndrome. And in this schematic, as you can see, this is a cut section through one single capillary loop. Okay, but under the microscope, what we see in actuality is something like this. So we see a glomerulus with its with its vascular pole here, then the proximal convoluted tubule coming out from the other side, and four glomerular tufts. Now, this is a more anatomically accurate schematic of what we see under the microscope. However, this is what the real glomerulus looks like under the microscope. Okay, so again, the proximal convoluted tubule here, the vascular pole is here, and as we've discussed previously, these are the capillary loops. These would be the capillary loops. You can see some RBCs within the capillary loops. That is, these are the RBCs, and then there's a mesangium in between. So this is the normal glomerulus. So after that, what we'll be discussing in today's in this under this heading will be histopath in the diagnosis of nephritic syndrome. So we'll try to understand the morphological spectrum of changes that correlate with the clinical presentation of nephritic syndrome. So this will include a non-crescentic immune complex mediated glomerulonephritis, crescentic glomerulonephritis, histopathological findings in specific etiological entities that are that present with a nephritic presentation. That would include Goodpasture syndrome, uh, IgA nephropathy, and your infection-associated glomerulonephritis. Um, that will be all that I'll cover here. But in the next discussion, we'll also discuss your histological correlates of specific etiologies that present with nephritic syndrome, sometimes with nephrotic range proteinuria. So that will be basically membranoproliferative glomerulonephritis, C3 glomerulonephritis, plasma cell dyscrasia associated glomerulonephritis, what has been called monoclonal gammopathy of renal significance, MGRS. And once we get into the histopath of that, we'll actually try, depict the entire spectrum of MGRS that is seen in pathology, on pathological on pathological histopath say, images. However, this will be slightly more extensive as compared to what I've discussed in the clinical presentation of these disorders. Then we'll finally end with histological correlates of microangiopathic hemolytic anemias. That is, we'll talk about thrombotic microangiopathies. So this discussion will end here. In the next discussion in this series, I'll be talking about the entities below this. Okay. So starting off, glomerulonephritis as the histological correlate of nephritic syndrome. So importantly, this is the histology of what I have discussed in the video titled An Approach to Peripheral Edema Part 4, that is glomerulonephritis Part 1. Okay. I would strongly suggest that either after watching this, you go and have a look at that video, or you watch that video first and then come back to this. So starting off with glomerulonephritis, the histological correlates of a nephritic syndrome. We're first going to talk about glomerulonephritis resulting from immune complex deposition. So these are the three schematics that we had used. And in the first schematic, what we have shown is that there is some degree of subendothelial immune complex deposition. And because of that subendothelial immune complex deposition, there is some degree of endothelial proliferation. And this endothelial proliferation is a result of what? It is a result of two things. One is there is the endothelial cells themselves have proliferated, or they have increased in their number. And in addition to that, there is neutrophil infiltration. So these white cells that I've shown inside the lumina of the capillaries are neutrophils. Now, this process can extend a bit further, and it can result in both endothelial proliferation as well as mesangial cell proliferation. So the green cells here are mesangial cells, so their number is increased. So that is your second situation. In the third situation, there is such severe capillary damage that there is release of inflammatory mediators into the Bowman space, resulting in an increase in the number of subcapsular parietal cells, what is called crescent formation. So again, the first situation is when there is pure endocapillary proliferation. Proliferation here meaning that there is an increase in the number of endothelial cells occluding the glomerulus, the glomerular capillary, and additionally there is neutrophilic infiltration. Second, we have endocapillary and mesangial proliferation. Again, there is occlusion of the endothelial lining of the capillaries lining the glomerulus, as well as there is increase in mesangial cells. And finally, we have endocapillary and mesangial proliferation, but with the formation of subcapsular parietal cell crescents. Okay. So under the microscope, this is what this would look like. Under the microscope, this is what the combination of endocapillary and mesangial proliferation would look like. And under the microscope, this is what endocapillary and mesangial proliferation with crescents would look like. So actually, I find it easiest to compare and contrast these entities with a normal glomerulus. So this is our normal glomerulus. This is the one that I had shown in the first slide. Okay. Now, in this particular entity, this is the vascular pole. Okay, this is the piece proximal convoluted tubule, and as you can see, there are open capillary lumens. That's why you can see RBCs within those capillary lumens very prominently. Okay, there are open capillary lumens. Now, compare that with this glomerulus. Okay, so in this glomerulus, we've got a vascular pole. We've got the Bowman space. We can't really see the proximal convoluted tubule. Now, some portions of the glomerulus appear to be normal. So at least this much part of the glomerulus appears to be completely normal. These are comparable. Uh, you see open capillary lumina and you see RBCs within those lumens. Okay. So that is the normal part of the glomerulus. But a portion of the glomerulus appears to be slightly different as compared to the normal. So here what you find is that there is definite occlusion of the capillary lumen. So there was a capillary here, that capillary is no longer there. There is a capillary here, there's only a single RBC there, most of the capillary is occluded. There's another capillary here, I know because there is a single RBC in the center, and that capillary is almost completely occluded. So in a portion of the glomerulus, we essentially have endocapillary proliferation. Okay. Now, how is that different from this second diagram? That is this diagram, this pictomicrograph. So again, this is the vascular pole. There we cannot see the PCT. Here, what we find is that there's a lot of increase in cellularity. It's almost as if the glomerulus has achieved almost a lobulated appearance, and we'll get to that later. But as you can see, a lot of the capillary beds are empty. There are small capillaries are open, but most of the capillaries, say in this area, there are very few capillary lumina that are visible. Whereas here you find a lot of capillary lumina, and there is a significant paucity of RBCs within those capillaries. So you know that the capillaries are occluded at some point. Similarly, there appears to be proliferation of cells within the mesangium. So this is a mesangial proliferation with endocapillary proliferation. Now, see, these two entities can look very similar to each other, but the important thing to note is that because the number of cells infiltrating and the proliferation of endothelial cells has occurred, the total volume of the glomerulus itself has increased. So it appears to be very full of cells, and as a result of that, it gets this very prominent lobulated appearance. Okay, whereas in this particular capillary glomerulus, I would find it very difficult to differentiate between capillary tufts. Here I can quite easily, say this is one capillary tuft, this is another capillary tuft. Okay, this is the third capillary tuft. So that lobulation, pronounced lobulation with a paucity of RBCs within the glomerulus, with a subjective, assessment saying of an increase in number of cells, is quite a clear, indication that that your patient's that glomerulus is showing uh, proliferation. And once you know that the capillaries don't have RBCs and most of them are collapsed, there is endocapillary proliferation. And in those areas of the mesangium that are away from the vascular pole, if you see more than three mesangial cells together, that would be mesangial proliferation. So there, as a result, deduction from seeing this pictomicrograph would be that there is a combination of endocapillary and mesangial proliferation. Now, a very similar process has occurred here. Okay, but in addition to that, there is also a subcapsular entity here. So there is a degree of subcapsular proliferation. So that is your subcapsular proliferation, and that subcapsular proliferation is what we call a crescent. Okay, so now see, all three of these imaging findings have occurred due to antigen antibody complex deposition subendothelially, with or without some deposition in the mesangium. But um, therefore, the thing is that these entities can occur in different glomeruli of the same biopsy specimen, that is, different glomeruli within the same biopsy taken from the same patient. Okay, so they form a spectrum of changes or morphological changes. Now, importantly, the significant number of neutrophils that are present in all of these histological sections indicate that this patient has got a infection associated gene. It is a soft marker that this is infection related. Okay. Now we'll talk about the specific histological entities that can present with this spectrum of changes. So in particular, just like we discussed in glomerulonephritis presenting with nephritic syndrome part 1, we're going to discuss anti-GBM syndrome, IgA nephritis, and infection associated GN. This would include your subacute bacterial endocarditis, and it will include post-streptococcal GN, but it also includes other para-infectious and post-infectious glomerulonephritis. So they have the same histological appearance, so there's no need to discuss them separately. So the first thing that we'll discuss is anti-GBM antibody mediated glomerulonephritis. So see, the thing is that there are two ways in which your classic crescent formation occurs. One is, as we just discussed, anti-basement membrane antibodies get deposited against the basement membrane in Goodpasture syndrome, causing extensive endothelial damage, and as a result of that, there is leakage into the Bowman space. Similarly, neutrophils that have been activated or primed while in circulation by anti-neutrophil antibodies can cause extensive endothelial damage and basement membrane damage together. So this is ANCA vasculitis, ANCA associated vasculitis, and this is your Goodpasture syndrome, or what is better called GBM, anti-GBM antibody syndrome. Both of these entities together can result in the same histological findings. That is what we just discussed. That is a subcapsular crescent with some degree of endocapillary proliferation. Okay. Now, so the histology looks the same. It's what we just discussed. Okay. So how would I differentiate one from the other? So for this, here I know that there is a deposition of an antibody sub in the along the basement membrane. Here I know there is no antibody deposition. So if I do immunohistochemistry, I'll be able to differentiate between them as long as I do immunohistochemistry the for those specific antibodies. So what I do is I take the histopath as a specimen and I do immunohistochemistry. So in the first situation, I get this pattern. That is, I get a prominent linear pattern. So it's almost as if the antibodies know where the basement membrane is, and as a result, they're getting deposited there. That is because the antibodies are targeted against the basement membrane proteins. So this is called a linear pattern. And if you have a linear pattern, the diagnosis then becomes anti-GBM antibody syndrome or type 1 RPGN. Okay, rapidly progressive glomerulonephritis. The second pattern is granular. So as you can see, unlike the first situation, here you see almost as if it's some table salt has been sprinkled over there. So there are granules of of immunofluorescence that are being seen. So if that is the case, then it is antigen antibody mediated. But these antigen antibody complexes are getting deposited subendothelially and to sub extent, and then they're in some situations dissociating and reassociating subepithelially. Again, I discussed this in detail in that discussion on the clinical presentations and pathomechanisms of glomerulonephritis. So I would strongly suggest you go back to that if this doesn't make sense to you. Um, so this would be immune complex mediated rapidly progressive glomerulonephritis. Now the third situation is that essentially there is no immunohistochemical staining. Okay, so as you can see, the same amount of staining is there in the interstitium as compared to the glomerulus. There is no difference between the two. Um, so this is a negative immunohistochemical stain. As you can also see, the intensity of the fluorescence is significantly lesser. Okay, so what do I find? I find that this is uh, type 3 ANCA-associated vasculitis. Now, please remember, this is not immunohistochemistry technically, this is immunofluorescence microscopy. Okay, so either way. Now, coming to your IgA, the second etiology, that is IgA nephropathy. Now, see, IgA nephropathy, we very conveniently have a classification system called the Oxford classification, and that allows us to quantify exactly to a very high degree of precision what exactly is the level of glomerular damage, and this predicts the clinical course of the patient much better than the clinical risk factors that we had discussed previously. Okay, so the first entity that is included in the Oxford classification is your mesangial hypercellularity. That is defined as the presence of more than three mesangial cell nuclei in a peripheral mesangial area. That is per one single peripheral mesangial area, not adjacent to the vascular pole. So importantly, there is a caveat that this measurement should be done in 2 to 3 micrometer thick pass stained sections. Okay, so whenever you're suspecting IgA glomerulonephritis, you must do a pass staining, and the histopathologist must ensure that the section thickness is 2 to 3 micrometers. Now, if less than 50% of the glomeruli are involved by this kind of mesangial hypercellularity, we give a score of 0. If more than 50% of glomeruli are affected, then we give it a score of 1. Okay. Now this is more than. Okay. Now, the second thing is endocapillary hypercellularity, and we now know what is endocapillary hypercellularity. So I'm not going to go back into it. But in case of IgA nephritis, what we do is we quantify it objectively using CD68 immunohistochemistry. Okay, so immunohistochemistry and not immunofluorescence, like we were discussing just previously. So this is more than 6 cells that are positive for CD68 present in the affected glomerulus. Okay, so that would be if it is less than or equal to 5, then you would give a score of 0. If there are more than 6 CD68 positive cells within a glomerulus, then you give it a score of 1. Okay. Now, here stands for segmental glomerular sclerosis. So this includes also adhesions of the glomerulus to the parietal membrane of the parietal glomerulus. Um, and if even one is present, then we give a score of 1. Okay. Then we have tubular atrophy and or interstitial fibrosis. Now, the important thing is this has to be assessed only in the cortical interstitium. So, if you have a medullary sample, it is not cannot be commented upon. Okay. Now, if less than or equal to 25% of the interstitium shows tubular atrophy, that is to be expected. It's not a big deal. If it is between 25 and 50%, then we give it a score of 1. And if it is more than 50%, that is a score of 2. Okay. And C stands for crescents. So basically, what percentage of the sample glomeruli show crescentic GN? So these crescents could be cellular, they could be fibrocellular, but we do not take into account purely fibrotic crescents. Okay. So if you have a less than 25%, then you give it a score of 1. and if you have more than or equal to 25%, you give it a score of. Okay, so this is your classification, is Oxford classification in case of IgA glomerulonephritis. Now, this can be remembered using the mnemonic MEST-C. Okay, this is the mnemonic that we use to remember it. And this is something that is important because whenever you see a biopsy of an IgA glomerulonephritis case, you will see this classification system being used, and it does predict. The higher it is, the more likely the patient is to progress to CKD, which is, as we've discussed previously, can be predicted using clinical markers, but that kind of prediction is not as effective as what you would get on biopsy. Okay, so let's just see what exactly this means. So in this first spectromicrograph, what I find is that a portion of the glomerulus has been replaced by this kind of uh, proliferation. Now, this proliferation is actually not affecting the capillary basement membrane. So the capillary basement membranes are spared. Okay, and this is the vascular pole. Away from the vascular pole, in this particular area, you got some mesangial increase in mesangial cell nuclei. So as you can see, there are 1, 2, 3, 4, 5, 6, 7 mesangial nuclei. So this is definite mesangial hypercellularity. So if that is present, we would call it an M1 lesion. Okay, and this is a fast stain, that is periodic acid fast stained section. So we would call this an M1 lesion. Okay. Now, in the second lesion here, what you find is, again, it's a very, busy looking glomerulus. Uh, and as I just mentioned earlier, there appears to be increased lobularity of the glomerulus. Uh, the number of RBCs within at least this area of the glomerulus is definitely decreased. Okay. And there is occlusion of the capillary lumina. So there is endocapillary proliferation. So we would call this an E1 lesion, and we're showing segmental endocapillary hypercellularity. Now, as I just discussed, this has to be objectively demonstrated using CD68 immunohistochemistry. So this is a CD68 immunohistochemistry stain. This is showing multiple cells, that is 1, 2, 3, 4, 5, 6, 7, 8. So in one single glomerulus, there are more than 6 CD68 positive uh, cells that you can see. Now, this is again a past stain, and this is showing a subcapsular crescent here. Okay, so this subcapsular crescent obviously would make it crescentic GN, and we would then be interested in how many glomeruli are affected. Is it less than 25%, less than or more than 25% of the glomeruli? Now, there are two findings that are not mentioned in the MESC classification or the Oxford classification. The first is these are actually renal interstitial vessels that are embedded in the renal interstitium, and these are actually arterioles. Arterioles in the interstitium showing a hemoglobin cast deposition. Okay, so this is something that you can see in IgA nephritis, and this is a large blood vessel showing onion skinning or proliferation of fibroblasts and pericytes around the blood vessels in concentric circles, indicating a sudden arteriosclerosis or acute arteriosclerosis as due to a sudden elevation in blood pressure. Now, these two entities are seen on the biopsy but are not included in the Oxford classification. Um, but they do correlate with the presence of acute kidney injury in patients with IgA nephropathy. They, however, do not actually correlate with a poor prognosis. That is why they are not included in the Oxford classification. Now, in addition to having your pure endocapillary plus mesangial proliferation and crescentic GN, you can also have a pure mesangial glomerulonephritis. So this is called mesangioproliferative glomerulonephritis, and the number of, as you can see, all the capillary lumina in this particular micrograph are open. Only in the mesangium here you find that the number of cells is increased. Okay, and we can say this is the mesangium away from the vascular pole because this is the vascular pole. So this is the mesangium away from the this is the vascular pole. So mesangium away from the vascular pole is showing more than 3 mesangial cell nuclei clustered together. Okay. So there are very definite causes of mesangial-proliferative glomerulonephritis, which I remember using the mnemonic fail. So you should not fail to find these. So that includes falciparum malaria-related glomerulonephritis. It includes IgA glomerulonephritis, which is why I'm discussing it here. It includes infection-associated GN, and it includes lupus nephritis class 3 and class 4. Now, the third etiology we'll be discussing is infection-associated GN. Infection-associated GN, as we've seen, this is the light microscopic findings. We've discussed this as part of the immune complex mediated pathology. Now, I'll just highlight a portion of that pathology, and it'll show a large section of it. So what you find is that in this large section, there is complete occlusion of the capillary lumina, and those that is due to multiple cells of different nuclear shapes. So there is one here that is relatively polygonal. There is one here that looks like a um, um, kidney bean, relatively oval one here, a lobulated one here. Okay, so possibly this is a neutrophil. Okay, this is a monocyte, or maybe this is a monocyte, and the other cells are endothelial cells that have proliferated. Okay, so this is what we see in infection associated GN. So the thing is, infection associated GN has got very specific findings, as I've just described. The first finding that you find is, importantly, your hypercellularity. So hypercellularity is loss of capillary lumina with a noticeable increase in the number of nuclei with a variable size and shape. Okay, so the variable size and shape is because these nuclei are both mesangial and endothelial cells. Okay. So additionally, I've shown you neutrophils, and I have shown you your subepithelial immune complex humps. So that we'll talk about. Okay. Now, in immunofluorescence microscopy, what we find is there is a granular deposit. Again, because the antibodies are getting deposited both subendothelially and in the submesangial location. Now, on electron microscopy, what we find is that this is the basement membrane. Okay, this is the podocyte, visceral podocyte. These are the endothelial cells. So in between that, in the subepithelial space, we have these electron dense amorphous deposits. Okay, so as I've discussed in the on our top or talk on the mechanisms of this kind of immune mediated damage, the antigen antibody complexes get deposited initially subendothelially, cause complement activation, and for some reason which we are not very clear as to why, they dissociate and reassociate subepithelially, likely to do with their biochemical nature. So this is highly specific. The subepithelial humps that you get are what you see in immune complex mediated glomerulonephritis, particularly infection associated GN, classically post streptococcal glomerulonephritis. Okay. Now, this is not to be confused with the subepithelial humps that you see in membranous GN. That is a cause of nephrotic syndrome, because the patient's presentation is completely different. Okay, so both have subepithelial humps. There in membranous GN, we have subepithelial deposition of the antibody, primarily causing podocyte damage, causing nephrotic range proteinuria because the basement membrane is no longer functioning properly. However, here the initial deposition is subendothelial, resulting in complement activation, resulting in damage to the basement membrane and the endothelium, resulting in nephritic presentation. But the antibodies, when you look at it under the microscope, are getting deposited subepithelially, and if you recall, because of that, because this is subepithelial immune complex deposition, the granular pattern is also not showing a pseudo linearity. Okay, so it is not showing one end edge of the granular pattern that is extremely well demarcated, because the outer edge is not abutted by the basement membrane. Okay. Okay, so the next discussion in this top series will be on membranoproliferative glomerulonephritis, which I'll be discussing as a separate topic in the next video. So before that, I would encourage you to see the approach to peripheral edema part 4.1, that is glomerulonephritis part 2. because otherwise, it'll again be difficult for you to follow it. So as of now, I've completed our understanding of the morphological spectrum of changes that correlate with the clinical presentation of great nephritic syndrome. This includes non-crescentric immune complex mediated GN. It includes crescentric GN, and we've understood how these actually form a spectrum, a continuum. And we have understood the histological correlates of three specific disorders, that is Goodpaster syndrome, IgA nephritis, and infection-associated GN. Uh, I will be subsequently discussing the histology of your membrane proliferative glomerulonephritis, C3GN, and plasma cell dyscrasia associated glomerulonephritis, which I have discussed mechanistically, but we'll try to understand the entire morphological spectrum of monoclonal gammopathy of renal significance. And finally, we'll end with the histological correlates in microangiopathic hemolytic anemia, that is your thrombotic microangiopathies. So that is it for this particular discussion. I'll see you in the next video. Thank you for watching.